My name is Bill Pienka. I'm a hand surgeon in Fort Worth, Texas, in the United States, and I'm happy to be here to present a historical review of midcarpal instability on behalf of myself and my colleague, Dr. David Wickman. Midcarpal instability has been known by multiple names over the years, and we'll provide a historical review today, as well as a history of the recognition of this disorder. Instability of the midcarpal joint was first described in the mid-1930s in an asymptomatic female noted to have instability of her wrist ligaments. It wasn't until nearly 50 years later that the term midcarpal instability was introduced by Dr. Lichtman, and this was broken into intrinsic and extrinsic midcarpal instability as a result of the etiology. Intrinsic midcarpal instability was further subcategorized into palmar, dorsal, or combined types, and extrinsic or adaptive midcarpal instability was reported as a result of distal radius malunion and more recently distal radius fractures. In 1984, White and Lewis introduced the term capitolunate instability pattern, or CLIP wrist, and they noted instability through the midcarpal joint that they attributed to laxity of the intrinsic wrist ligaments. Also in 1984, Johnson introduced the term chronic capitolunate instability and described instability through the midcarpal joint that they attributed to laxity of the intrinsic wrist ligaments as well. Patients had a painful wrist clunk and subluxation of the midcarpal joint in the dorsal direction, and they were treated with palmar radioscaphocapitate ligament reefing that corrected the midcarpal joint subluxation but resulted in loss of wrist extension. 13 years after the introduction of the term midcarpal instability, the Mayo Clinic group, Wright, Dobbins, and Linscheid, introduced the term carpal instability non-dissociative, which they subcategorized into SIND VC, or volar direction instability, SIND DC, or dorsal directed instability, or a combined type of carpal instability non-dissociative. They described 38 patients that they treated with either soft tissue reconstruction, joint leveling procedures, or midcarpal fusion, and had just 56% good or excellent outcome with no benefit of surgical management over non-surgical treatment. The introduction of the terminology non-dissociative was to differentiate this condition from the previously described dissociative carpal instabilities within the proximal row, namely scapholunate and lunotriquetral instability. This condition has been described using several different terminology over the last 40 to 50 years, all describing the same or similar pathology. Midcarpal instability and carpal instability non-dissociative, or SIND, have persisted as the commonly referred to names for this condition. The pathogenesis of midcarpal instability is incompetence of the ligaments that stabilize the midcarpal joint in the proximal row. This laxity may be the result of congenital etiologies, may be acquired, or as a result of trauma. Instability through the midcarpal joint in the dorsal direction appears to be a result of laxity of the arcuate ligament. Palmar midcarpal instability, or SIND VC, appears to be due to laxity of the dorsal radiotriquetral ligament, and there's some recent evidence that periscaphoid laxity, or STT joint involvement, may contribute as well. In palmar midcarpal instability, when the wrist is in neutral, there's flexion of the proximal carpal row with volar subluxation through the midcarpal joint and a VC appearance on the lateral X-ray. When the wrist is brought into ulnar deviation, the proximal row stays flexed until it reaches full ulnar deviation, where there's a sudden flip from flexion to extension instead of a normal gradual extension, and this is what causes an audible and often painful clunk. And you can see here the midcarpal shift test being performed on one of my orthopedic residents can be positive in patients that have midcarpal instability. There is some controversy regarding what to call this condition though, as some authors and surgeons prefer the terminology SIND, while others prefer the term midcarpal instability. It's important to ask ourselves, is this condition truly non-dissociative? The true pathologic anatomy has not been fully verified, but we do know that acute disruptions of the dorsal radiotriquetral ligament will lead to palmar midcarpal instability. This will lead to a lack of synchronous action between the carpal rows. That ligament laxity can also be developmental or acquired and not truly dissociative. Further confusing the terminology are recent reports of traumatic non-dissociative carpal instability. And while we recognize that the proximal row is actually what's unstable, not just the midcarpal joint, the injured ligaments do cross both the radiocarpal and midcarpal joints, and they may be either lacerated, avulsed, or stretched. The terminology SIND was introduced initially to distinguish this entity from the proximal row dissociative lesions where the SL or LT ligaments are torn. But the ligaments responsible for stabilizing the midcarpal joint can be developmentally lax, stretched, or torn and result in various degrees of subluxation or dislocation of the midcarpal joint. And lack of proper function of either the intrinsic or extrinsic stabilizing ligaments can therefore either be dissociative or non-dissociative depending on the magnitude of the ligament disruption. And we believe that the terminology dissociative and non-dissociative really have nothing to do with the location of the ligament pathology, simply describing the magnitude of the effect. In this table, we put these subcategories for midcarpal instability and SIN next to each other, including the primary pathology, surgical treatment options, and incidence, to show that these are really two terminologies for the same condition. In summary, I want to stress that midcarpal instability and SIN are terminology describing the same set of disorders, and what you call this condition is much less important than recognizing and treating it appropriately. We do believe, however, that we've been doing a field a disservice by continuing to perpetuate this confusion by referring to this condition by two names over the past 40 years. And while neither terminology is perfectly correct, we do prefer the term midcarpal instability and believe it to be the more anatomically correct terminology for this condition. I'd like to thank you for the opportunity to present a historical review of midcarpal instability and welcome any questions at my email seen on the screen.